Well, it's Christmas Eve, 2015, and we're here in my office. I'm Dr. Jim Pritchett, and I have one of my patients with me today. A great thrill to have Dr. Fred Buechel from New Jersey, and he's going to tell us about his now very personal experience with hip resurfacing. And I want to start off though with asking Dr. Buechel, why hip resurfacing? Why should anybody have hip resurfacing surgery at all when they could have a hip replacement?
Well, I say hip resurfacing is a hip replacement because you're using the most physiologic arrangement that you can have. You've got the patient's own femoral head and neck, acetabulum that was put there by God, and if you can load it properly by just capping the proximal femur and putting an appropriate bearing liner in there and have all the muscles heal up, you have a normal hip joint. You have a normal range of motion, minimal dislocation problems, and if they live a decent life and the bearing doesn't wear out, this hip resurfacing can last 20 to 30 years. But it gives you the option, especially for young patients that are only in their 20s or 30s. They're going to look at 2 or 3 more hip replacements in their lifetime. Why not give them the best chance of preserving the bone? And if they had a decent enough bearing, they might get the 20 to 30 year life that you want before they have to get a stem. So I look at resurfacing as an initial primary hip replacement for everybody. I don't think it should be considered a subspecialty use, but I think it's a primary hip for everybody because you want a hip that's going to last you as long as it can, and when it fails, you want to have maximum number of options. That means stems, bearing changes, and so forth. So for me, hip resurfacing makes absolute sense from standpoint of a primary procedure and stalling for time for the young active patient and allowing them to go back to all their full activities.
Right. So you mentioned some dates in there. I think this is another very compelling, interesting aspect. So with the retirement a year or so ago of Harlan Amstutz, and then 9 years ago Dr. Townley passed away, it sounds like you might be the most experienced person still around in hip resurfacing from the time window. So you were before McMinn, before DeSmet, and some of the other surgeons. Would that be a fair statement?
I started resurfacing in 1976 while I was still a resident. And I was working with Dr. Pappas on redesigning some of the sockets at the time. For instance, the Indiana conservative hip had a large socket. We actually took it to a machine shop and machined it back so it was less than a hemisphere. And that allowed it to be recessed in the bone, and we cemented the cap on, cemented the sockets, and a lot of them, they worked fine. We just brought the cups down a little bit so that they got recessed inside the acetabulum. So we started early, 76, 77, and finally decided in early 80, 81, 82 that cement seems to be a problem with resurfacing. So we went cementless starting in 1982. And then we added our little short stem on the femoral component after looking at the work of Jude and Townley that used stems to try to prevent fractures of the neck. And I didn't particularly like the length of the Townley stem, which would tend to stress shield the upper bone. And the Jude stem was a little too straight and too thick. It was a tri-flange nail. So I made a composite of the two with a tapered, unporous coated stem to protect the neck from a fracture. It was used for alignment purposes and to prevent neck fracture. And we came out with that one about 1993. It was probably the first one ever in existence because all the resurfacings thereafter seemed to copy that particular early design. And the cementless fixation worked fantastically. So I've been very happy with fixation. It's always the bearing that's been the biggest problem until the last 10 years. highly cross-linked poly came out. We've been using it in our resurfacings now for 7 or 8 years, and they're like nowhere. So now suddenly I think the final gap, which was the bearing, seems to have been solved. So cementless fixation of resurfacing, to me, is no question. It works. It's solid. It's dependable. But it's the bearing. Now it looks like the bearing, as we get closer to 10 years with bearings in resurfacing, then I'm going to be real enthused about this being the primary hip replacement of choice, and that everything else is a revision. The primary stem that everybody uses today so frequently will become a revision. And I think resurfacing should take its rightful place back where it belongs.
Could you show us the example of the hip and
This is
what are some of the
a
features?
This is a Buechel Pappas resurfacing hip. It's gold in color, which is titanium nitride ceramic. It has a polyethylene that's recessed inside of a shell. It's anatomically shaped with an inferior cutout to allow the iliopsoas to pass by without causing any irritation. It's porous coated on its inside, but not on the stem, to allow bone to actually grow into this femoral head. And it's got porous coating on the back side of the socket to allow bone ingrowth. There are fixation holes in case you need to have a screw to augment fixation, but most of the time they can be put in without screws. To me, this is the state of the art, this particular bearing, especially using it with highly cross-linked polyethylene. Right now, I won't do a resurfacing with standard poly anymore because I know they wear out in 5 to 10 years, and I'm looking for 25 to 30 years. And that's what I think we're going to get with the highly cross-linked bearings.
There's interest now in polyethylene again for resurfacing from some of the large vendors now. There's I understand a program under place at Smith Nephew. They're looking to make a one-piece acetabular component, so a metal backing against the polyethylene. They want to make it even thinner. What do you think about doing that, or is this the optimal component that you could ever get to?
If they want to make a thin shell acetabular component,
Yeah, they're trying to match the thickness that metal, since it's one piece, can offer. And they thought is make the polyethylene, maybe take that down to 3 millimeters even, or slightly less possibly, and
Well-
just put the metal backing directly on it so that is that the right way to go, or is this the safest, best way to do it?
well, in the 70s, they used thin polyethylene acetabular cups. And in the 70s, acetabular loosening was a big issue. The thinness of the cup means that it can be more flexible than a thicker cup. And so the cement mantle around a thin shell acetabular cup may suddenly start to fracture loose, and within 10 years you may see that very thin cemented shell loosen. What we've seen with these devices now for over 30 years is they don't loosen with this metal shell. We also have seen that this thickness polyethylene in highly cross-linked poly doesn't seem to wear. The older ones with regular poly, they wore out in around 10 years. Some of them lasted 20 years, but that was unusual. So we know regular poly goes about 10 years. Highly cross-linked now on simulator studies, it goes 60 to 90% longer. So since we know that these shells work, they've been working now for close to 30 years. And there's no reason not to continue using these shells with a better poly.
So if that shell was dimensionally thinner, would it, your concern is it would be too flexible and might loosen or clamp on the femoral head? Is that what
Yes.
the concerns would be?
The shell, Mike Pappas optimized this shell thickness for two things. One was for structural stability, so that the shell didn't fracture. If you make it way too thin and you have screw holes in it, you've got little stress risers all around the shell. We don't know if it would fracture, but we haven't seen any of these fracture in like close to 30 years. So we know that his computations on shell thickness back in the 80s has held up over time. So once I know that, why do I want to reinvent another shell when I know that this shell actually really works? All you're doing is now saying, well, will it work? And now I have to wait 20, 30 years to find out. Well, I've already waited 20 to 30 years and I found out that this shell, this thickness, exact dimension works. And it works reproducibly. And the only thing that we worried about was the poly. Now I think we've got the solution to that. So we're there. I think we're there.
Comment on the, if you can, on the, one of the concerns that orthopedic surgeons in general have about resurfacing, about the demanding nature of the surgery and its relative precision. You find this is a skill that you can export to others, that they can perform resurfacing at the level that it needs to be technically to be successful?
I think it's a difficult operation. It took me many years of trying every approach to get it to a point where I thought it was fairly simple. I went from anterior approaches, anterolateral approaches, posterior approaches, Smith-Peterson approaches, all these various approaches, and I finally came down to the posterior approach, cutting the capsule completely around and dislocating the head superiorly and anteriorly was the easiest approach. And I think you may have come to that same conclusion.
I did.
And most of the time you have to cut the gluteus maximus tendon and then make sure you repair it or sew it back into the femur at the end of the case for extra exposure. It's a tough exposure. And so a surgeon has to be a good hip surgeon to start with. He has to be prepared to be frustrated to do these things. He needs to learn it from somebody who's very skilled at it. Because if he tries to run through this thing and slap these implants in, he's going to become disappointed. We have an implant that has a track record, has a history, there's a story behind it, it's made for a reason. It's not just the latest thing off the shelf from a company with no documentation and no follow-up. They go, okay, then let me try that device. I have the skill set. Because the skill set is definitely a skill set that's not easy. You've done it yourself probably more times than I have.
Yeah. Well, I found the implant a very good performing implant, but it's another level of complexity beyond Birmingham hip to use, in the sense that it's a little thicker, and that puts a little bit more pressure on getting the exact head-neck ratio that I can get to on the femur, to conserve acetabular bone. At this very same time, also a very fastidious acetabular preparation, so that I don't over deepen the medial wall or the anterior or posterior columns. Birmingham being just a little thinner, you have a few more millimeters of acceptable tolerances. And I find this implant works probably better if I have the bone preparation that I want, but I find when I'm doing the procedure I need to go back and forth,
Right.
prep the femur a little bit,
Right.
then go back to the acetabulum until I get that complete sweet spot. Much of that I'm doing now on our digital radiography with my template in advance, because we can.
Right.
Would you find that that's also the case, that you have to be a little bit more sophisticated yet as a resurfacing surgeon if you're going to use this implant, or would that be your...
Yes, I agree.
Any thought that we'd start with the plan of resurfacing and need to change to a total hip during the operation? Is that a realistic concern a patient should have, that will happen during their surgery?
I think every surgeon should prepare the patient for that. In reality, I don't think it's happened to me at all. In 30 years or over 30 years of resurfacing, but it's always a possibility.
We'll move on to why you're here in Seattle on Christmas Eve. It's not just a vacation. So, tell us about your experience and your own hip and how you decided what you would do relative to that.
Well, in my own case, I have bilateral femoroacetabular impingement problems. Then the last 3 years, all my motion started to go away. I had 0 internal rotation, only about 5 degrees of external rotation. It was painful to walk on, and it just wasn't working. I was stiff, I couldn't get my shoes and socks on. It just wasn't working very well. And I've always been a proponent of resurfacings, and I love the natural feel of having your own femur work for you. Then I knew that you did a lot of these resurfacings, and you probably had the most experience in the United States on this type of a resurfacing system, especially using my own components. I was pleased to find that you felt just as strongly as I did about them, and it made me, my choice of surgeon was a no-brainer. I wanted the guy who knew how to do the job technically correctly, and you're an excellent technical surgeon. You're using implants that I thought were superior with highly cross-linked poly, which we struggled to get that for this set of components. It took almost a year for us to get these components because it's just not generally available. You have to go through hurdles because of our FDA. They tend to just strangle anybody who wants to move forward and progress in the orthopedic industry. So we overcame those hurdles, and I was so pleased that you decided that you would take me on as a Christmas present to me. And here we are on Christmas Eve, and I'm giving the Christmas present back to you, that your patient is grateful for what you've done.
What was it like to be a patient of our practice and at the hip center, orthopedic center that we have here? What's the experience been like?
I had a great experience here in Seattle. The pre-op preparations and all went flawlessly. I came with my better half, Karen, and she was amazed at how they just moved me from spot to spot very seamlessly. Got into the OR, you showed up early in the morning, gave us our final blessings before we got off onto this, and within a day I was going home. So I went home the very first post-operative day after 3 sessions, actually 4 sessions of physical therapy, 1 on the day of surgery, and then 3 the following day, using my Canadian crutches to get me around. First I started with a walker, and I felt comfortable enough with the Canadian crutches to do everything I needed to do. They took me up and down the stairs, got me in and out of a car, got me on a toilet seat, got all this stuff done very skillfully by your rehab staff. And before you knew it, I was like, wow, I guess I am ready to go home. Who would have thought? Besides, the food is good here. The food was exceptionally good, and you have your own menu. So you can order your own menu off, as much as you want, anytime you want. I would have stayed longer just for the food.
Any reason that a patient should be concerned about coming from out of town to do this?
No, we were a little apprehensive about it,
Yeah.
but Karen found a nice a place within a mile away, and in your list on your package, it happens to be one of the mentioned executive suites, I think, around the corner. And we've been very pleased with staying there. We booked in for 2 weeks because I thought it would be proper for me to see you after surgery. Don't want to get on a plane too early. 2 weeks, I think, is even pushing the envelope for that. But I'm on anticoagulation with aspirin, and I move around a lot, so I'll do my best to avoid that. And that's the only issue, is the pulmonary embolus issue. And as long as you're moving around, taking your medications, I don't see a problem coming from out of town, because if this is where the best can be done, then you should come here.
If we, Karen, Lonnie, you guys want to get on camera here?
tears out of my eyes.
Yeah. Great. Yeah, get surrounded by the fam. So, a real important part of our program that we have, and this, of course, you guys wouldn't know about this, is Susan, my assistant, and I have it's a two-way street. Patients do pick us, but we pick them. And mostly it's actually the support that they have. They have to produce a support person that will help get them through this. And the qualities of that person, they have to be confident, they have to be reassuring, they have to know the person they're supporting, and be willing to make this kind of commitment from one person to another. What we can't have is someone who wants to not produce a supportive person to help them through it, particularly if they're from out of town, and or someone who's just too darn nervous and worried and speculative and not reassuring. And instead of making the person confident and less anxious, they make our patient more anxious and less confident.
Right.
It's a really key part of what we do. It's essential. It's beyond all else what we need for an out-of-town patient. We just can't do it any other way. It's probably I do know quite a bit about resurfacing, but I think I know a lot more about what it takes to get someone through the process and all, because it's hard. It's surgery, and it's not. You have to be perfectly mentally prepared. Well, great. Last thing I want to do is during the examination we went through, which we had about an hour ago here in the examination room, and took x-rays and all. I was given this lovely book by Dr. Buechel with a very compelling inscription, which he read to me and shook my hand. It was really fantastic. This is a real treasure of a book to have. And, this would be my first. I've done 4,400 hip resurfacings, but I've not been given a book about it. And I haven't yet done one on somebody who did a resurfacing further back in time than I have yet. And it's a thrill. I don't. This couldn't possibly be repeated. There simply isn't. This will never happen again. This is truly a totally unique experience. Not only do I have a fantastic patient who's done well, that's the only reward I want anyway, but to get a book on top of it and an experience to learn more from my patient than they learn from me, that's a fantastic thing for me. It's a really great to have. I also want to thank our film crew. The filmmaker, Charles, also known as Chuck Schwarzbeck, his assistant Avi, for rolling out on Christmas Eve at their standard rates. All right.